Welcome back, everybody. We are so excited to be here once again. This is the last episode of us talking about CIRS, Chronic Inflammatory Response Syndrome, mold-related illness. Hopefully, you've already put your questions out there because that's what we're doing today. We're going through all the questions you asked. If you haven't liked us, followed us, subscribed, shared, those are all the things that can help get this information out. But also for those who had questions, let you know a new episode pops up so you can listen to your questions being answered. So we're going to hop into it and go through all these things. There we go. So actually,
There we go.
There we go. Awesome. So the first question is actually from YouTube. You mentioned the cell danger response. Please describe it. Talk about it. Is this valid? A model for chronic illness, and what is a treatment protocol for it? Cell danger response, in my mind, it's kind of like the advanced next level of chronic inflammatory response syndrome of all chronic illnesses. So why don't you, Dr. Jenski, kind of explain to us what this thing is? Then we can talk a little bit about that.
I think it is the model for chronic illnesses and why we're seeing such a rise, as you mentioned and alluded to. And the validity of it has been proven by Robert Navio and his work, and ultimately that was kind of pioneering, and almost to the point where on the back end of him describing it, all the people reading about it, learning about it, and discussing it, it was like, okay, we have a medical text that we've learned. Now we need a second medical text that accounts for all this new information that kind of centers around this. And ultimately it boils down to the mitochondria and how they are essentially our canary in the coal mine. The mitochondria is the cell sensor. It's detecting internal and external environmental inputs and then telling the cell, informing the cell what to do next. Do we continue to repair? Do we regenerate? Do we shut down? And in this case, it's the shutting down. And so there's literally a cycle that the mitochondria are kind of bioenergetically cloning themselves out, or biogenically cloning themselves out, and making all the things that they make for the body to work appropriately in the setting of an individual that isn't sick. In this situation, a signal, an injury, a trauma, a toxin is detected, and the system says it's time to go from being a power plant to being a battleship. Let's shut it down. So you have arrest of the cycle, and you will not complete that cycle and repair and regenerate until A, the perceived or true injury, toxin, insult, infection, etc. is resolved, and then that cycle can be turned back on. Because sometimes it's enough to just remove whatever that insult is, and then it switches back on. Other times you got to remove the insult and then nudge it along and hope that they're not stuck in this kind of fixed state of cell danger response. And that's where the whole limbic dysfunction and other things kind of come into play. So the shortest version is that it's literally your mitochondria going from being power plants to becoming battleships. I'm no longer making energy. Now I'm cowering in the corner because we're under attack, we're fighting, and we flip into this inefficient state of metabolism called aerobic glycolysis, and it's arrest of resolution and repair.
I think one thing that's really interesting is it also explains why patients who we give them methylating agents, we give them nutrients, they have the actual opposite reaction.
Yeah.
They herx. It's like you have no B1, you have no omegas, you have whatever, and now they're having these crazy responses. It's because their cells are stuck, and you're trying to make them go forward in the cell cycle. And so that's now explains to us these patients who had the opposite reaction to expect our therapies because of this thing. And so all of a sudden, like, there's that aspect of it. Then there's also the aspect of it, which I think Dr. Neil Nathan talks about, which I think is really insightful, that you do all this stuff, you remove the mold, the Lyme, you deplete the nutrients, but the brain, the limbic system, the spinal cord, the autonomic nervous system still thinks danger, Will Rogers, danger kind of thing, you know? And so then it's like the brain retraining comes into place after you've done everything, which has been our clinical experience.
Yeah.
And it's been the experience of people doing this for years. Now we actually have a biological model that explains these weird reactions to folate and B vitamins, and why you got to do brain retraining for these patients.
There's memory, right? There's memory with these instances. So when a cell itself, the mitochondria itself, detects danger, whether that's a cell extracellular, the presence of extracellular ATP, or DNA damage, or a toxin, or damage to the lipid bilayer, or whatever the case. There's all these different insults, or even just like a shearing force and traumatic stress. There's a whole host of mechanisms by which the cell says something's not right. And when it determines that something's not right, the mitochondria determining that informs the cell that we have to do this now. And this is self-preservation. So you're coming along whether you like it or not. But there's memory attached to that situation. Just like you have memories attached to traumatic events in your life, even though that trauma is long gone, you still have some hardwired traumatic innate response. That's where this comes into play. And so in order for this loop to kind of finish and to get that cycle turned back on and to get the resolution and the repair, again, it goes back to not only do you have to figure out what harmed it, what sent this signal to begin with, and what do I do about that, then do I have to start doing something about the memory? Do I have to create a state of amnesia almost, or do I have to rewire the system?
Yeah.
And that's important because that lends itself towards hypersensitivity. I mean, think about all the hypersensitivity patients that you see that have these HERS reactions that you described, that can't tolerate anything, that you give them a little bit of extra fiber and they feel worse. Like it's just kind of, it's sad but true.
Yeah.
And like those are the patients that are clearly hardwired in this way. Yeah. And like that is at its core chronic diseases, but for us, very much a centerpiece of SIRS. Yeah. Like this is the cornerstone of SIRS. SIRS is a mitochondrial illness. It is mitochondrial toxicity, it's hypometabolism, it's a stuck cell danger response, it's flipping into aerobic glycolysis, and that's where you are until you get your environment right, you eradicate Marcons, you normalize a VCS, you get them on VIP, and you turn the cycle back on.
Yeah. So this is like the next generation of stuff. Yeah. This is like part of that advanced chronic inflammatory response stuff, which neither one of us learned in our training. Neither one of us learned. We literally, I'm like how many 5-6 years to this, and now I'm just learning about this.
Yeah.
But it makes everything else makes so much more sense once you understand this. This is an interesting question. What percentage of your patients in recover? We talked about this before at CIRS. What's the average time frame when patients start to see improvement in clear Marcons?
This is just it comes from a place of frustration. I get this because as a SIRS patient who has recovered from SIRS, there's 1%, right? Like I don't know. It depends on the number that you're pulling from. No. But the reality is that this is completely situation and patient specific, and it depends on the why behind SIRS. Now we've talked in other videos about statistics, and 80% of SIRS patients are sick building, and 20% are the outliers, and some of that's Lyme, some of it's other infections, some of that's traumatic brain injury, some of that's X, Y, and Z. And so it depends on why they have SIRS, and then B, if it's an ongoing issue, how quickly they get better depends on how quickly they address the stuff that's outside of our hands. So I can handle the medical aspect, you can handle that, and it's still complicated. But then when you're layering in that this is your home, and we're factoring in the price tag of remediation versus moving, and contractors and their competency versus incompetency, like did we find everything? Are we doing all the right things? There's so many variables, so many layers, and it just stacks on. There's no linearity to it. The clearing of Marcons is the rate limiting step. It pisses everybody off. I'm in the same boat. It took me 2 years to see a negative Marcon result. But in hindsight, it's because I didn't know that I had an ongoing exposure when I was traveling for work. I was frustrated because I did all the things to get my home right, but I was an ER doctor in locum staying in a hotel for a week at a clip, once or twice a month. And so it was like, of course I was taking a mold hit. And so I would come back thinking, oh, it must still be my home, but in reality, it wasn't. And when I finally put 2 and 2 together and I stopped traveling, I eradicated Marcons because my home truly was right, and I moved forward. So it's dependent on the individual. I have a couple of individuals that have already gotten their home buttoned up, and by the time they see me, they just needed proof that something was wrong, a documentation of SIRS, some anti-inflammatory binding, 1 course of Marcons treatment, and they're better, but that's the exception to the rule. Like that's just really rare. I mean, is that your experience as well?
Yeah, my experience, if we catch it on the front end, like you've had SIRS for 3 to 6 months, maybe less than a year, we catch it early, and you address the house immediately. You address your diet immediately. You address your Marcons immediately. You do all that stuff immediately.
Yeah.
I've seen people turn around 3-4 months.
How often does that happen?
That's uncommon.
That's rare.
When that happens, I jump up and down. I'm so excited. I'm like, it works. It works.
That's the impetus to go on.
That's the impetus to go on life. Yeah, go on with this because you're like, it works, right? The more often than not, this has been going on for 5, 10, 15 years.
Yeah.
The brain's hardwired in this cell danger response, and even when you do everything right, it's so hard to convince people that your brain's been rewired. It's been wired for illness. They almost interpret it as it's all in my head. I've actually had this conversation with people. Are you saying I'm crazy? Are you saying it's not real? I'm like, no. This is called psycho, neuro, immuno, endocrinology. This is like the mind-body thing.
Yeah.
Whatever you want to call it. It's like the deep magic of what we do, where your mind literally controls everything. And that, because we stigmatize that so much, and people have been gaslit, it's all in your head, nothing's wrong with you, you know, all this kind of stuff, that when you say, let's work on this, they're hearing
you saying the same thing differently.
Yeah. And that's where it's, and I've had patients that's taken 1, 2, 3 years to finally get to the point that, okay, I think I believe what you're saying.
Yeah.
I'm gonna start some stuff.
Yeah.
And I've had patients do that, and that's when everything, like, all the lights start flipping on, everything starts changing, they start healing.
Yeah.
And so it's everybody think this is true precision, individualized medicine. You have to trust it, like you like to say, you gotta trust the process.
Yeah.
You say it to your patients all the time, trust the process, walk through it. And the thing is, if you're not getting better, we're missing something. What is it?
Yeah.
And I say it all the time, what am I missing? You know, am I missing some weird infection and whatever? Are you still getting exposed? And when you do that 2 or 3 times, then it's always like, okay, you've done this, wash and repeat, wash and repeat. And almost, I won't say almost all, 9 times out of 10, it's like your brain is stuck in this trauma state. And we have to literally rewire your brain. And that realization sometimes is harder than my house is an issue, I had a tick bite.
Yeah.
You know, sometimes that's harder because
it's way harder because it's so less tangible. And it's a lot of personal work that's also difficult because it's revisiting something that you are repressing, or it's revisiting something you didn't even know was there, or an aspect of your health that isn't even really all the time objectively measurable. And so it's one thing when I tell someone something and they believe me, great, and they don't believe me, but then I show them objective data and now they believe me. But what if I tell them something and they don't believe me and I have no objective data, and it's like, this is just based on my clinical acumen and the fact that all this other objective data looks good and I don't think we're missing anything. It's a little bit of a harder sell, but then when they kind of commit to it and all of a sudden things start to get better, that's that aha moment. But you got to get that patient there, and the reality is you got to meet them where they're at. And if they're not ready for it, they're not ready for it. If you push them, you'll make them worse. And so that's part of the process too. Sometimes trust the process is maybe we just hold space right now and we don't move forward. But when there's low-hanging fruit, before you expand out to look for more problems, like go after the low-hanging fruit. That's the only thing that's logical in my opinion. All right. So the next one is, do you only do the pupil test or tremor test? And this was when you were talking about physical exam findings that were kind of cool, just for CIRS or just for dysautonomia patients?
The tremor test specifically is one of the physical exam criteria associated with people with chronic inflammatory response syndrome. So it's not a diagnostic thing. It's part of your physical exam. I think I have these things. You do a physical exam, and when you see that tremor, you see that, well, we'll talk about the adrenal pupil in a second. It's like, yes, I've got physical exam findings. It's like someone's, someone has a head injury, concussion, you're doing like their neurological exam. They close their eyes, they fall over. Yeah. It's like, okay, cool, you had it. You really did have a concussion, right? And you close your eyes and now the room spins kind of thing. The pupil test is more of a marker for, is there dysregulation of your autonomic nervous system between your sympathetic and parasympathetic? I'm in the room with a patient. I don't feel like I'm a threatening person. Shine a bright light in their eye, and their brain says, bright light. That's parasympathetic, which is part of the rest and digest. It goes down. But their brain is like, no, I'm not safe. And so it pushes it back open. But then the brain's like, no, bright light. And so you see that you can literally see this undulation.
Yeah.
And it's such a cool thing to see, because when you see it, you're like, I think I've done with some patients that done a video of it. He's like, what was that? And they see it, they're like, that is weird. And that's that battle. So that tells me that there's a degree of dysautonomia. Yeah. Like that pupillary dilation lives in your brainstem section, the same section that regulates your autonomic nervous system. Yeah. And so it's more of a marker for dysautonomia, one small version of it. But then it's like, I've got gut issues, maybe you have gastroparesis, biliary dyskinesia, maybe you've got POTS, maybe anxiety is your POTS. And so these are just physical exam findings that give us as, this is not online medicine, this is not virtual medicine, this is like us as clinical physicians who have an expertise in making a diagnosis and doing a physical exam, using the physical exam aspect. The NASA lean test is another great example of that, where I check someone's blood pressure laying down, sitting up and standing, and if your systolic blood pressure shoots up or drops, and your pulse goes up over a certain number, then it's like you have probably POTS, which is a part of dysautonomia. Why? Right. And you start going down, is this your Lyme or your SIBO or your mold or your MCAS or your hypermobility, and all of a sudden you have clinical exam findings that support our presumptive diagnosis based on story, And then as someone goes through the treatment, we can say, oh, you're not doing the people thing anymore. Your blood pressure's stabilized, And so just part of being, we're clinicians. It's what we do.
Objective metrics.
Objective,
That was really well said. That's a perfect explanation. Like literally going from, I suspected this based on what you told me. I found this on exam. I'm now playing detective and looking at the why behind it. And here's my treatment plan. And now the reassessment is that it's getting better. Plus, so are your numbers. That's excellent medicine is what that is.
That's the reason we do certain types of, tendon reflux. It's the reason they'll test for peripheral neuropathy, which is associated with some kinds of dysautonomia and mold things. It's just part of our physical exam because we're doctors. We're clinical sleuths, I guess. So.
The next question, pretty straightforward. You want to just jump on this one too. So what are SPMs? I guess we didn't explain that one. And then what type of fish oil? So I guess we're looking for specifics as far as like clean sourcing and things of that nature.
So SPMs are these things that actually pro-resolving mediators. And so when you have an injury, your body creates inflammation. Inflammation is actually good in certain situations. You get an infection, you get a bruise, you get injury. Your body has inflammation, which is instigated by these inflammatory mediators, omega-6 based metabolites. So those are like your omega-6 prostaglandins, basically your 3 and 6 series. Those are ultimately formed from omega-6 fatty acids. So pro-inflammatory fatty acids, you want that response. Pro-resolving mediators are the opposite side of that coin, or the 3 series that come from omega-3s, which are anti-inflammatory. Eventually, omega-3s turn into these pro-resolving mediators or inflammation mediators. And so it's this really cool biohack where some people don't convert, flax, right? Don't convert ALA to EPA to DHA, right? So sometimes we have to bypass that with nutrients to push the enzymes. This is a way we can jump down, I don't know how many pathways, 10 to 15 pathways.
Give the end product.
Give the end product. Yeah. It's an anti-inflammatory. Doing 4 capsules twice a day can treat acute pain. You got a backache, you got a headache, that if you have cycle pain, it actually works nice with that. So we're using these omega-3 end products that come from your ALA, which is usually flax and things like that, omega-3s, and bypassing your body having to turn it into that. So we're actually using, that's like a drug, basically.
It's kind of like giving methylfolate to somebody who's got an MTHFR gene, right?
Great example, yeah.
I can't convert folate into methylfolate. Okay, here is the end product.
If you give them folic acid,
even worse.
Bad things happen. So it's like you think it's folic acid, bad things, 5-MTH, really, really good things.
Yeah, it's a leapfrog hack. I love it. And they're powerful because it's anti-inflammatory, but anti-inflammatory almost in an immune anti-inflammatory way, because it also flips your macrophages from M1 to M2 stage. So pro-inflammatory to anti-inflammatory, pro-resolution, which is cool. Just being mindful of in certain conditions, inflammation is caused by chronic infection, and resolution of inflammation will make that infection worse. Again, it's about a clinician who understands this stuff, picking and choosing their battles and understanding when to implement these strategies and not just taking them all day, every day, the same way that you can't just take antioxidants all day, every day, and then when you need an oxidative burst to fight an infection, it's not there because you're suppressing it. Yeah. It's about balance, right? What about fish oils? What are your go-to?
So fish oils, omega-3s. The thing about fish oil people don't realize is that omega-3 oils are heat sensitive and oxidation sensitive, which means how long can you leave a fish in your fridge before it goes bad? A couple days, right? That's those omega-3s going rancid, right? If you ever cooked a fish, it's yummy, whatever. After 3 days, I will burp fishy, right? Yeah. And so with omega-3s, if you get a expeller pressed or some kind of heated omega-3 or in that solvent, so they actually use solvents to extract the omega-3s, then all of a sudden you're getting a rancid oil with solvents, and we're doing the exact opposite of what we're going to do. Or let's say the omega-3's been on the shelf, or unfortunately sometimes in the summertime when it's really hot, we had this happen at our house where we got some omega-3s in the heat, and it gave my wife really bad reflux, and it was like it came out like one of the hottest days of the summer kind of thing. And so when you do omega-3s, you want to make sure they're, how do they actually get the omega-3? Are they using like a CO2 extraction process? Are using molecular distillation? Which molecular distillation is what HVAC guys use to get water out of your HVAC. They create a vacuum, which lowers the boiling point of water. It boils out of your HVAC, and that's how they get water out of the thing. So we take fish oil, we put it in a vacuum, we lower the boiling point so that it boils at room temperature. You take off, you basically distill off the omega-3, and you've done this at a room temperature, cool temperature. So, and then sometimes you'll cap them with nitrogen capping so that it doesn't go rancid. So that's what you want to look for. And so the brands, I mean, I like Designs for Health has a really good one that that is molecular distilled. Thorn has one.
I like Nordic Naturals.
Nordic Naturals has one.
Metagenics has a good product.
Yeah.
And I keep mine in the fridge. You can put them in the freezer.
After you open them, put it in the fridge.
Yeah.
And after you open the fridge, you got 4 to 6 weeks to use it.
Yeah.
And after that, if you haven't used it and you start burping fishing, then it's time to dump it.
And most of these are sardine, mackerel, and
small
chili
fish,
sauce, that kind of stuff.
And if they're molecular distilled, one of the things is they're tainted with solvents or chemicals or metals. It's a way to actually purify it as well. So ultimately, my thing is first and foremost, do no harm. Let's say 20 years from now, we find out vitamin D doesn't do anything for you, C doesn't do anything for you, fish oil doesn't do anything for you, which, just pretend that happens.
Yeah.
The bare minimum one knows I have not hurt anybody, which means I haven't given anybody mercury from the fish oil.
Yeah.
I haven't given anybody lead because they're calcium supplement, 25% of calcium supplements on the market and have lead in them.
Yeah.
So the very minimum I want to do, which is kind of hard these days to do, is like, yes.
You make any suggestions, there's always that risk.
Yeah, exactly.
All right. So again, this is kind of piggybacking on the success rate one.
I think we answered that.
Okay. But this one talks about I guess that is, it says that a lot of practitioners talk about this being relatively straightforward. I don't know who they're seeing. I'm very upfront with my patients, and I say this is nonlinear, and it's never going to be linear.
No.
The best case scenario is, like you said, we're catching it early. You're doing all the things that we ask you to do right on the front end, and then it can become as linear as possible. If you think about how many confounding variables there are from external environmental sources, this is not linear, but Heyman's work took shoemakers and made it as linear as possible, but even then, within the individual, it's not linear because cases are different. Cases are specific. Environmental exposures are as well. All right. Well, let me read this one.
Okay.
Hi, I'm a patient of Dr. Jenski's. Hello, whoever this is. I adore these series. I've watched every episode. Oh, this is a hard one.
Okay.
My family thinks CIRS is made up. Have you heard that before?
Never.
The data doesn't support. Not true. Hard to replicate in studies. Can you explain why traditional medicine thinks this and what the counter argument is? I've listened to the whole series, and that's the part I don't get. If there are biomarkers to show, like C4A and TGF-beta, then why isn't it more widely accepted? Are there explanations that mainstream medicine has for that? Are there studies on PubMed that I can look at? I'm just curious to know if there's any compelling evidence linking mycotoxin exposures to Parkinson's disease. I've read a lot about it, and I'm not sure how strong the evidence is yet. So this is, I feel for this person because this is not uncommon, but I'll let you kind of jump in on this, and I'll add as necessary.
And I think the basic thing is medicine sequential, step-by-step, increasing knowledge? Is that the way medicine works? We talk about science as if it's this linear thing. It changes based on paradigm shifts. We used to think the earth was flat, right? And so we interpreted things like ships going off the horizon as being eaten by sea monsters. We had no idea how to explain, the sunrises and sunsets. As soon as we realized, hey, the thing's round, we got things called nautical miles. I mean, ship people had known for millennia before you can't measure straight miles. These things called nautical miles because you actually could around. Well, all of a sudden now we had, now I understand nautical miles. Now I understand ships going over the horizon. I actually understand the prism effect for sunrises and sunsets, right? Medicine science goes with paradigm to paradigm to paradigm. And so we're in the part of a paradigm shift. And so, the thing I tell people historically, Ignaz Semmelweis, the guy who invented hand washing, lost his career over it, was jailed because he's crazy, right?
Yeah, he was deemed to be a lunatic.
Yeah, he was actually beaten back when he used to beat the crazy out of you, died from the very infection he was trying to prevent, took 30 years to catch on. Smoking in our country, back when I was a kid, it was like, I want a smoke-free place. Well, you're crazy. There's no science that says smoking's bad. But we were like, that's weird or wacko. Like in the 70s, the AMA was like, there's no evidence that smoking's bad for you. It took 50 years and 7,000 research articles before the Surgeon General of the United States said, you know what? We think smoking causes cancer, right? And so it's one of those things like, this is just the way science goes. And so science is in these ivory towers, and it's very much a trade. I practice medicine the way my mentor practiced medicine, the way he practiced it. And so it's really easy to get in these ruts. And so as far as that's the reason why it's taking forever. Shoemaker discovered this in 96, 98. It's actually been taken up way quicker than hand washing was, to be honest with you, and other things. Smoking, we still got 20, 30 years to figure out that mold's an issue. But it's interesting, the EPA recognizes that water damaged buildings are our thing. They actually termed the term sick building syndrome back in the 80s, just another name for the same thing. There are white papers out on this. Building biologists, which is a whole different field of science, knows that we can come in, we can check, they have meters to check CO2 in the building, and that tells you how many air exchanges the building has. They do things to check formaldehyde, the soot off-gassing. So there are fields of science that understand your environment affects your health. Because that's all this is. It's saying your environment affects your health.
Yeah.
And even with endotoxins, which are one of the things we talked about in Europe, and this is a shoemaker, something down this pathway when I was doing my training with him, did research on endotoxins in Europe. They have data, they actually measure endotoxins in cities to know air quality levels for causing illness. So there's so much data out there. It's going to take 30 or more years before we learn this in medical school. And that's kind of where we're at.
We didn't learn just the whole umbrella of environmental medicine is just not taught.
It's not taught in medical school.
And this goes beyond CIRS and water damaged building or sick buildings. It's like we didn't learn about heavy metals. We didn't really touch in
nutrition.
Yeah, it's so the reason that it's kind of poo-pooed or dispelled or dismissed is because of exactly everything that you just said. They just haven't caught up. But also this speaks to a bigger issue, which is that the way medicine is set up right now is that it's been fixed on a downstream disease label prescriptive Band-Aid model. And it's not individualizing it, it's not looking upstream, it's not trying to use nutraceuticals. Everything seems to be a medicine and then a medicine for that medicine. But it's all what's going on wrong inside of this person's body. What's the disease state that I can put a label on? And the reality is that we have to consider our external environment as well, and that input on that internal environment, and that surface isn't even being scratched. So to take something as complex as this and assume that they're going to go from nothing to this is a huge leap of faith. Yeah. And so the best thing to say is that if your family doesn't believe you, I'm sorry for that, but the reality is that the data is there, it has been there, they're just not caught up. Go to PubMed, go to Google Scholar, type in CIRS, type in actinomycetes, type in mycotoxins, type in cell danger response, and you're going to get hundreds of thousands of articles. Yeah. And it's all there for them to happily read and see if they want to be on board with you and help you get better.
Yeah. And it's just one of those things that's where I think marketing comes into play.
Yeah.
Education comes into play. Perception's reality.
Yeah.
And if you don't hear about it on wherever you get your news from Twitter or Facebook or Instagram, wherever people get the information, you're not hearing about it from your regular doctor or your specialist. People assume this doesn't exist. But there are textbooks, for example, on side effects from drugs. 30% of pharmaceuticals are mitochondrial toxicants.
Yeah.
This is standard pharmacy 101. A lot of medications have side effects, like you put someone on a diuretic for their high blood pressure, induces magnesium deficiency.
Yeah.
What happens? You get palpitations, and you get potassium deficiency, you get insulin resistance. So next thing happens is the person develops palpitations, they get put on a beta blocker, which further makes more insulin resistance. Yeah. 10 years later, they're diagnosed as a diabetic.
Yeah.
And the question is, are these medication side effects? This is in textbooks. I was not taught that in medical school. I was not taught to connect the dots of drug-induced metabolic complications.
Yeah, same.
And so there's so much of that. And that's why that's the reason we kind of geek out in this kind of medicine.
Yeah.
Because it's literally, we're going to spend the rest of our lives just figuring out stuff.
Yeah.
I'm still trying to figure out stuff.
Yeah, same.
But yeah, I'm sorry for that person, because that's unfortunately a lot of people's reality, and it's heartbreaking hard.
It's hard, especially because the complexity of this requires support, and if you're not feeling supported, then it makes it even harder, and it's already hard enough. So that's why we're here. This one I was confused by because I have not read this or heard this. Shoemaker said in one video, patients would ruin their therapy by taking curcumin at the wrong time. No further explanation. This makes me wonder and gives me insecurity. What could this possibly mean?
I mean,
I don't have any explanation as to where at any point in a CIRS patient curcumin would hurt them. I mean, step one is bring the neuroinflammation down. Yeah. So that's curcumin.
Well, that's where I think this is so cutting edge. You won't find people who think We've talked about different kinds of mycotoxin testing.
Yeah.
This is actually Heyman and some of his stuff, like curcumin's used early on
Yeah.
as a brain anti-inflammatory. Dr. Goodnow, who some people may have heard of plasmalogens, he uses a specific kind of curcumin called desmethoxycurcumin, which specifically protects the brain from endotoxins.
Cool.
So he does that in autistic kids, and he has a specific thing for that. So we know that this actually helps protect your brain from endotoxins, primarily in your gut in his case, but obviously environmental ones. Curcumin is really cool because it mimics what butyrate does. So if you're not getting enough butyrate in your gut to help protect your brain, you can take curcumin. So I'm not really sure. Do I have people take curcumin, have reactions with it? Sure. I have people take everything. The current literature says doses up to 10,000 milligrams a day are safe. There's actually, if you're a patient who sees me with MGUS, which is a kind of pre-leukemia thing, there's literature on that actually slowing progression of MGUS. It's a particular kind of curcumin with biopterin, but point is that it's a really cool thing. I think we all should take it.
Yeah.
Some people don't tolerate, just like some people don't tolerate other stuff. Without seeing the specific reference, I don't know what this is referring to.
Yeah, and I like Resilio too, which is the nanotized lipophilized one that has like better bioavailability than IV curcumin. It's literally like getting right up to your brain, taking care of that inflammation. I don't think in any of these patients at any point along the way that's going to be detrimental or cause a setback or be problematic. So I think this was maybe some misguided information.
It's hard to know because there's so much stuff. People will say, well, Dr. X said this, and you actually look on it, and just clickbait, and you actually read. In our literature, you have an abstract. I've read research articles where the abstract is not supported by the body, and you're like, this is like medical clickbait.
Yeah, it is.
Like, oh my gosh.
Yeah.
So it's hard without seeing the actual reference. It's really hard.
My practitioner only uses mycobind as treatment for CIRS. I'm going to assume that person's probably a naturopath if they can't prescribe Welchol or cholestyramine. So do you think I should ask for cholestyramine or Welchol? I'll let you answer this, but I guess quickly, if the person's only using mycobind, it might be because they can't prescribe the others. But if it's a medical doctor that can prescribe these, then that might just be their comfort level. Do you want to speak on the differences of those?
Mycobind, there's one article looked at how well these bound bile acids sequestrants. And so, cholestyramine was number one. Welchol was a little less.
Yeah.
I think it was
so much more tolerable.
Yeah, well, that's the thing. The ultimate thing is I have this perfect thing that's the best thing. It's cholestyramine. You're supposed to take one packet 4 times a day.
Yeah.
How many of your patients actually tolerate that?
And it's chunky orange juice, and it has fake sugars in it, and it gives you mad heartburn.
Yeah, you said enough.
And
right?
then I have this other thing called Welchol that are tablets that you can swallow without any of that, and it's only 3 times a day.
Yeah.
Which would you choose?
Yeah, and then it's like
all my patients get Welchol.
Yeah, we
mycobind for the sensitive ones.
Yeah, well, that's the thing. Is like if you have a lot of sensitive patient, a lot of people cell danger response or other MCAS stuff. Because you can actually get an acceleration reaction. It's like a cytokine response with cholestyramine because it's pulling out toxins too quickly. And maybe the person's just bypassing that aspect because they've had so many side effects.
Yeah. Don't you see that in Lyme patients a lot?
Yeah.
Okay.
Well, that's and those people you say load up on your SPMs and your omega-3s first, give it a month, let's try again.
Yeah. Yeah. Doesn't Marcons drive inflammation?
Yes.
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 Yes, it does.
Yeah, we talked about that a lot in this series. I don't think we need to.
Yeah. All right, I'm going to read this one because this is for you. I wonder if Dr. Hartman knows anything about severely advanced CIRS and how this is essentially useless information and a waste of time. Thank you. Methylene blue is the only thing that will stop the CIRS reactions. Advanced CIRS also renders your lungs unable to process the sense of smell without violent intense sickness. You also separately lose the ability to eat because you become seriously allergic to everything. It causes damage to almost every organ, destroys your mind, and unable to function. All this doctor stuff is nonsense. Just take 12.5 milligrams twice a day of pure USP grade methylene blue. If you have advanced CIRS and have money to spend, go see a doctor, but they will 90% not be able to stop the reactions as good as methylene blue.
Okay, wow, there's a lot of things in there. So first, I think of the advanced CIRS, whatever that is, I think that's like what we're talking about, these really sensitive patients who develop multiple chemical sensitivity, limbic kindling. They can become so sensitive that they react with EMF.
Yeah.
And all of a sudden now the LED lights in this room or your cell phone make them feel kind of ill.
SIRS is not black or white. It's a continuum.
It's a continuum, yeah.
Everybody's different. This is
Yeah.
personalized.
Yeah. As far as the methylene blue, USP grade methylene blue, which is bought online typically, has heavy metals in it. And so the first thing is don't ever buy your USP grade. USP grade only is saying that we're verifying the dosing. That this is 10 or 15 or 20 milligrams. It truly is 10 or 15 or 20 milligrams. It's not verifying purity.
Right.
And if you buy something online, usually it'll have cadmium, it'll have other heavy metals in it. So don't do that. Just get a doctor to write you.
Yeah, get your compound pharmacy.
Yeah, and it's clean. So
which we use.
Absolutely.
You use a lot of on your
I
patients.
use a lot of methylene blue actually.
Yeah.
But methylene blue is really interesting. It was actually originally created as a dye. It was like one of the first dyes in the 1880s to dye stuff. Hence the word dye. By the 1890s, they're like, wait a second, this helps with malaria. So they started using it with malaria until this thing called quinine came out. And then just kind of fell inside. But then in the 40s or 50s, they said, hey, there's this thing called methemoglobinemia, which is another mitochondrial thing where people can have enough oxygen in their blood, but they still die of hypoxia because the blood doesn't release the oxygen. And so methylene blue will reverse this, right? So it started used in the hospital. So this has been around for a really, really, really long time. Probably maybe 20-ish, don't quote me on this, maybe 20 years ago, people started realizing, hey, you can use this for chronic Lyme patients because methylene blue helps break down biofilms.
Yeah.
It also has antimicrobial activity. You can use it with patients with chronic UTIs. There's actually a prescription. The word came in with Urabel. Urabel is a prescription medication used by fancy urogynecologists here in Richmond. It's got some antispasmodics for the bladder. It's got methylene blue in it. Mm-hmm. So this is used commonly for a lot of things. It was recently, maybe in the last 3 to 5 years, it kind of crept into the biohackers because methylene blue, by chance, is electron donor. So it acts at the third, this is a little more fancy stuff here, but it acts at the third complex in the mitochondria, which is where oxygen works to help make energy. So methylene blue, like NAD works at complex 2, between 1 and 2 is CoQ10, right? 1 is riboflavin, I believe.
And then complex 3 is cytochrome C, right?
Cytochrome C, I think, goes between
connects the two. It's the chaperone.
Yeah. And so this is the kind of medicine we do every day. And so, but that's where methylene blue fits into it. So I've had patients who've had fatigue illnesses, and I've used methylene blue, and it's actually made so they can work out and not have a push crash phenomenon. I've used it with some of my Lyme patients, and actually with some of the newer ILAD stuff, methylene blue is actually being used not first line, but really close second line with some of these Lyme patients because they have co-infections with Babesia and Bartonella. Yeah. So it's really, the question I'm curious is, did this person have a co-infection?
Yeah.
Do they have some other mitochondrial thing going on?
I have no doubt that this person is feeling better on methylene blue, but I do doubt that they're getting the whole problem solved. Because if this is truly a SIRS case, and in their words, advanced SIRS, the only way that we have documented evidence to reverse SIRS is VIP, vasoactive intestinal peptides. So they'll get close, but you're not going to fully get out of SIRS with methylene blue alone. I'm sorry, it's just not going to happen. The reality is it's probably helping to address underlying infections diagnosed or otherwise, biofilms diagnosed or otherwise, and maybe a little bit of mitochondrial boosting, and that it's dose dependent. Methylene blue, certain dosing will do different things. It's not uniform in its functionality at every single dose. A higher dose versus a low dose is going to give you, whether we're talking about anti-aging or biofilm disruption or antimicrobial properties or mitochondrial boosting. But if your mitochondria are stuck, then you can give all the mitochondrial support you want. It's not going to do much. I've done this. I've thrown methylene blue and PQQ and CoQ10 and B vitamins and magnesium and NAD and all the things at someone who I know has a mitochondrial issue, and they're like, hey, my energy's a little bit better. Yeah. It's because it's stuck. Get it unstuck, move it along, resolution repair, then all that stuff will light them up like a Christmas tree and they'll feel fantastic on the back end of it. Yeah. But there's utility for it. It's just, I just think that's kind of maybe more coming from a place of frustration.
Yeah, I understand. The thing is that, ultimately that's the reason why we did this whole series. And we did 7 videos before this, and I did the blog thing. It's been out there for years. Is that so people can have reliable information? Yeah. The reason we're doing this verbal because this hour we talk would literally be probably an 80-page blog, which I'm not writing anything.
Yeah. And the reason that people get it online, the USB grade, is because it's cheap.
And it's
expensive when you compound.
It is, and they don't need a licensed provider.
Yeah.
It's kind of like, I don't want to say that, but it's kind of like when people will go to animal feed shops to get certain antiparasitics, which I won't say here.
Or peptides.
Or peptides online.
Yeah.
And usually...
Slippery slope.
All right. So next question is, how long does it take for symptoms of mold-related illness to appear? I think in episode 2 or 3, you gave your bucket analogy and when things kind of... So why don't you kind of give that to us here?
Sure. So ultimately what I tell my patients is that we're born try to visualize that you're born with this empty toxin bucket. And ultimately, based on your exposures throughout life and your genetics and your metabolic byproducts, the choices you're making, some things that you have that are outside of your control, the bucket starts to fill up. And in this case, we're speaking specifically about biotoxins. And if you're in the genetic subset where you are susceptible to biotoxicity, then ultimately you're not able to empty that bucket. So each exposure, you're collecting some more and it's filling up. You leave the environment, you take them with you, you come back, you take on some more. And as that bucket's filling up, you may or may not be all that symptomatic, and it really depends on the individual. But clearly, as it's filling up to some extent, you start to see those other aberrations of that cascade that we've spoken about as MSH starts to lower and leptin starts to go up. And the reality is then at that point in time, that person tends to start to have symptoms. At some point, you hit critical mass and you overflow your bucket. And that's when we deem that you're flipping into CIRS, Chronic Inflammatory Response Syndrome. At that point, you're definitively symptomatic. So for some, it might be 10, 20 years. For others, it might be that they buy their starter home, unbeknownst to them, their crawl space is a travesty. All of a sudden, they moved in within a year, they have all these new symptoms. They're seeing all these doctors, they have a diagnosis, they catch COVID, that pushes them over the edge, and next thing you know, they're in CIRS in 2 years. So it really depends on the person, but it's really about exposure, extent of exposure in each individual situation, and then over time, not to mention how open or closed your detox pathways are based on genetics and lifestyle.
Yeah.
All right, how about what do I do? This is always a hard one.
Yeah,
What should I do if I think my workplace has mold? And is there a link between mold exposure and asthma?
If you think your workplace has mold, first thing, just talk with your boss. Say, hey, I've got these issues, et cetera, et cetera. Hopefully you're working with a reasonable person that will at least go into it. 50% of all buildings in the country have water damage. So
it's a high likelihood.
It's a high likelihood that's either between your home and your workplace or your place of worship or your friends' houses or places your kids play that there's mold somewhere. So it's hard. Talk with your boss if you think it's an issue. Hopefully they're willing to work with you to do some basic evaluation or have someone come out and look at it. But like with the usual things, it's like who's going to come look at it? Is it going to be a building biologist or a duck guy who just was going to look at one thing? And that's where you hopefully whoever you're working with knows the right people to do that, and just make sure you get the right people to do it. Because I routinely have people who will be like, someone came out and checked for mold, and they did plates. Yeah. They came out and did cultures, and so did they do a particle count in the air? Did they check for VOCs? Did they do in your crawl space? Did they take an infrared gun, a FLIR gun, and look for temperature changes in your wall? Did they? If the answer is no, it's like you probably didn't have the right person. Yeah. So
and it goes beyond mold too, right? Yeah. It's biotoxins.
Well, that's the thing is mold represents 16% of the big thing. They're not looking for other stuff. The asthma thing, is really interesting. When I did my training, one of the numbers I used was 25% of childhood asthma was related to environmental mold. And I read this past year, 75% of adult asthma is related to environmental mold. Yeah. So I know I tell people somewhere between 25% and 75%. Yeah. But the gist is if you have kids with asthma, check your crawl space, check your house. If you have an adult with asthma, check your house out. Because, those numbers are highly, highly suggestive of me that probably most cases of asthma in our country have at the bare minimum environmental, if not an internal environmental mold component.
There's layers to that too. I literally, because I was seeing patients today before we started doing this, the last patient I just saw, she straight up told me the house she used to live in was a brand new build. She had no breathing issues. I'm treating her for CIRS. The house she lives in now, they just finished remediation and now they're doing the extensive cleaning and all the things that we've talked about. But she's been flaring as like gangbusters, and she hasn't had an asthma flare since she was a kid. And so clearly there's one that has correlation. The next layer to it is if you no longer have mold in your home, it doesn't mean your asthma is going to automatically get better if you're Th2 polarized immunologically from biotoxicity or chronic hollow space infections or excess cortisol. So just that I am being a mole patient or I'm a CIRS patient makes you stressed out. That's going to drive up your Th2 histamine asthma response. So there's a direct correlation, and then there's layers of the onion, as there is, that we can always peel back.
One of the health risks associated with mold exposure, I mean, pulmonary hypertension. Someone asked
neuronal
about
atrophy.
Someone asked about the Parkinson's board. There's a correlation with neurodegeneration.
Yeah.
I have a patient,
So Parkinson's, dementia, even ALS, I think they're trying to draw links to.
Yeah, they are, I have an individual work. Have you seen a case of CIDP before?
I have, yeah.
Okay.
He's CIRS.
Okay, yeah. I've seen two. The one was when I first started my career, so I didn't know about this back then. The current one is a CIRS patient, so that's interesting. So from asthma to dementia.
Yeah.
It's a big...
And all the things in between.
Well, there's
hormonal stuff. So all the hormone stuff, pick it.
Yeah.
All the gut stuff, autoimmunity, skin stuff, clearly mood stuff, neuronal degeneration.
Someone asked earlier on, I don't think we asked it, or it's coming about psychological issues. There's a psychiatrist,
that's coming up.
Mary Ackerley, who's, when I was doing my training, she was one of the lecturers for Dr. Shoemaker, or maybe it's this, I lose track, maybe it was an MCAS stuff I was doing.
Mm-hmm.
Anyway, she's a psychiatrist. And what got her down this pathway was some bipolar schizophrenic patients who she found had mold issues, addressed it, and their genetic psychiatric medication-controlled issues went away.
Interesting.
And so her thing is now, mental health, neural inflammation with seriously ill people.
We'll talk about that more with that question, but that leads me to the neuroquants that we do on patients, the ones that we're getting locally. When you look at the extended breakdown of it, the way it's analyzed, besides looking at is this mold-induced or PTSD or subjective cognitive impairment or TBI, there's a schizophrenic column and there's a bipolar column. So we're seeing a lot of overlap with these structures and the neuronal atrophy that we're seeing that are literally almost paralleling on top of each other, and that's currently being studied. And then the other health risk that I don't think gets talked about enough, and I think in my lifetime we'll start seeing more of it, is the cancer risk. I think think about how these environmental toxins are just affecting your body negatively. And if you have, as you can measure on a Gini, defective apoptosis or mitochondrial dysfunction, the metabolic disease that ensues, isn't that a breeding ground for cancer?
Historically, we learned this in medical school.
Yeah.
Historically, wheat gets aflatoxin, and people get liver cancer.
Hepatocellular carcinoma.
Yeah,
that's what my grandfather died of.
Yeah, and so
primary hepatocellular carcinoma. Guy never drank.
Yeah, and we know that in the food system, being exposed to particular kind of toxins, aflatoxins, one of the many ones, is directly correlated with certain kinds of cancers. So is it correlated with breast and colon and other unassociated ones?
To be determined.
Probably. If I was to guess,
can CIRS cause POTS, and can CIRS be cured?
CIRS absolutely can cause dysautonomia. POTS is a type of dysautonomia.
Yeah.
Can CIRS be cured? It can. We have literature now. We have patient experience of that. We talked about that before. It's just a journey.
Yeah. And it just disclaimer, you cure it, you get out of CIRS, but then you're not done. Then the real work of understanding of how you got there and the vigilance of, I know what my kryptonite is, and I have to understand that environments hurt me, and I have to make sure that I avoid those at all costs, but there's an inevitability. And when I suspect or know that I'm exposed, I got to know the things to do to make sure that my bucket doesn't overflow again and I don't flip back in. Because your genes don't change. They will stay the same, so you just got to own it.
Yeah. And we have patients who get Marcons again.
Yeah.
They start going downhill. You retest them, then they treat them.
They get pissed off.
Yeah, and then they go to someone's place, and so I have patients now who are like, if you know you're going to some place, take your cholestyramine the week before, prep your body. Maybe start doing your betadine nasal saline flushes. Prevention kind of stuff.
I have patients do nasal protocols when they get on planes. Yeah. I just stay on my binders because why not? They don't hurt me. So
just take your B vitamins. Yeah. Take your fat soluble vitamins.
Yeah.
And So mental illness, next
Yeah,
question.
this is the one. So you were started on this, so I'll just read it and then you can kind of keep going. So I think you probably have some great stuff to say on this. So what are your thoughts on mental illness? Do you think it's an end diagnosis or is it a symptom of something else like CIRS, Lyme, et cetera?
Mental health is a kind of neuroinflammation, whether it's schizophrenia, which does have a genetic component, but now we're seeing you can have environmental triggers for it, whether they're recreational drugs, or whether they're mold-related kind of stuff. We know from the 1960s there were actually things you can't do now. There was actually a psych hospital. And back then, when people were in the hospitals, they were really sick, and they put them on a gluten-free diet, and they saw significant. They basically removed it. They forcibly removed it. We know information with ketogenic diets, treating seizure disorders and other neurological issues, including schizophrenia. Massive response. There are certain types of bipolar disorder. There's a prescription drug that methylene. It is L-methylfolate dosed 5 milligrams, 7.5, 15 milligrams, massive doses to treat bipolar depression. So all of a sudden now these symptoms that have names, that have DSM-5 names to them, actually are just syndromes of other things going on, whether it's a person with MTHFR or a mold patient or a Lyme patient or a post-concussive syndrome. We know that post-concussive syndrome can cause significant neuropsychiatric issues. So, the thinking, the people don't realize our current thinking of psychiatric issues. Where in medicine, Dr. Jenski, are you doing the exact same thing they were doing in the 1950s? We're basing our psychiatric treatment on the neurotransmitter model. Yeah. It's been the same model for 70 years. Yeah, I can't really think of anything we're doing that pretty much the same.
Yeah.
And a lot of medications we use, their precursors were created in the 50s and 60s and 70s. So we're at this inflection point with psychiatric illnesses, realizing it's a bigger thing.
And I think that movement is catching on pretty quickly, which is a good thing to see. And I mean, you gave just a couple of examples, and there's so many more, but like these same diagnosable, billable conditions, that one was due to an infection, another was due to a toxin, another was due to a nutrient deficiency or inability to methylate appropriately. And so, yes, these are symptoms, in my opinion, of something bigger. And I feel like IBS and fibromyalgia and a lot of other things that get a label and a stamp are also that way. And you're not going to know if you don't do the work and you don't play detective and you don't dig deeper. And some people are comfortable just sitting with that label, but most aren't, especially the ones that come here to see us.
Well, a lot of times when things get these labels and criteria, it's initially for research purposes. So we have criteria. How do you define rheumatoid arthritis?
Right.
Well, now we got this thing called mixed connective tissue disorder, which is kind of like rheumatoid, but it's Rh negative. It doesn't quite meet the criteria. So you get these criteria, so then you can actually do a FDA-approved study or a pharma-approved study, or you do some kind of study to collect data. But a lot of these descriptions are on the front end are actually created. They're complex, complex regional pain syndrome. Before that, it was there's a name for complex regional pain syndrome. Before that, it was reflex sympathetic dystrophy.
Yeah.
The name changes because we have a new criteria for it. That's driven by our understanding from a research perspective. And as clinicians, these are all nice ways to think, but ultimately we don't let them confine how we think about patients. Yeah. Because our primary goal is to help people, not click off boxes for
and label them
for for
which they unfortunately internalize or it stigmatizes.
Yeah.
All right. Can you explain the CIRS and long COVID link? Can COVID kick you into CIRS?
Yes, it can kick you into CIRS, and we are now finding out that long COVID is a CIRS phenomenon.
I think it's CIRS.
Yeah, I mean, some people are saying it's a mast cell phenomenon, which is some of the thinking about that as well. Which is probably a CIRS. Well, it's really,
not all CIRS, but like
it's not CIRS, it's not. But this is where I think the controversy is, because depending on the expert that you are and how you're looking at it, that's the paradigm you look at things. And so I'm humble enough to really, the way I think of, I tell patients all the time, anything I say, you can't hold it to me for more than 3 months. Because I have
before, but how do you get away with saying this?
Because I say it all the time. Right? Because and people respect, that's good, because you're learning, you're reading.
Yeah.
You're still, I've changed how I do lipid stuff in the last.
It's your way of saying I don't know everything, and I never will.
I'm still learning.
Yeah.
I'm still learning.
Yeah.
So I think the point is, yes, we've seen with COVID reactivation of Lyme, reactivation of Epstein-Barr, of CMV, reactivation of HSV. And I was learning this last fall at the ILADS conference. In their infectious disease world, they're seeing COVID being a reactivation of dormant infections, which sounds a whole lot like post-Lyme syndrome or chronic fatigue from EBV, So, can I definitively say that today? No, but
will it be proven? Yes.
Probably. Yeah. We have enough,
And the other thing is that the working multidisciplinary model for what long COVID truly is we think it's a combination of these things, and then they start to list them, and it's inflammation and immune dysregulation and mitochondrial dysfunction and oxidative stress. What does that sound like to you? CIRS. So
and that's one thing with the CIRS when people say mold. I'm like, again, it's 16%. Right. You got this 20%.
I correct people all the time. It's semantics, but I have to because it's misleading if you don't. And I'm trying to undo the confirmation bias that everyone's falling prey to because it then allows me to feel like I wasn't misleading them into thinking it was just mold. And when they've got their third or fourth mold inspector out saying there's no mold, it's because there's bacteria there, or it's because it's something else. Like I've already said that more than once. Like that's my whole point of saying, please don't say mold. This is a biotoxin illness. Please don't say mold illness. It's
biotoxin.
Yeah, it's CIRS or chronic inflammatory response.
And I also refer back to Dr. Yehuda Schoenfeld. He's I'm brain fart. Yehuda Schoenfeld. Anti-inflammatory syndrome induced by adjuvants. And so he has 4 major things, and one of those is silicone in plants. And one's actually adjuvants. He talks about metals like aluminum in vaccines. But the thing was, in reading his textbook, he has a great textbook on vaccines and autoimmunity written by experts around the world. It's a great read if you haven't read sometime. But he talks about before we used metals as adjuvants, and now we're using mRNA as adjuvant, and we'll go down that pathway. We use petroleum products called prunes and non-prunes adjuvant. So petroleum products, do we use petroleum products and petroleum distillates in anything around us? Like everything, the question with Roundup is Roundup's so bad because glyphosate's a toxin, or that 93% of the inert ingredients in Roundup, petroleum distillates. Yeah. So, and all of a sudden now, can these things attach to your cells, change the protein structure, okay, and create this thing called molecular mimicry? Mm-hmm. Yeah. Can that induce autoimmunity? Yeah. And now it's really interesting because I was actually telling Dr. After about this, and a lot of things in the mast cell world is you get these pseudo-auto antibodies. It's a mast cell phenomenon, talking with him, that you get these small antibodies. Well, we see that with petroleum, with chemical exposures. Yeah. And so I feel like a lot of us are looking at the similar phenomena with a different mindset. And it's up to practitioners to take that information and apply it to the myriad of patients we see. Yeah,
and that leads into the next question, which is about mast cell histamine stuff. So essentially, I'm curious what happens if you develop mast cell activation syndrome / histamine issues. If you treat CIRS with a mast cell activation syndrome, histamine go away since you treated the root cause. It's the only root cause.
That's the thing. What's the root cause? With mast cell activation syndrome is a part of the pentad super syndrome, which is mast cell is MCAS, autoimmunity, GI issues, which include like a whole host of things, hypermobility,
and
dysautonomia. Yeah. And so, like when you see MCAS, the question is, okay, does this person also have a little bit of mild dysautonomia? A lot of times they do. Are they hypermobile? And we could talk about the hypermobility. Is that an MCAS phenomenon? Is that a genetic, one of these things we have this genetic predisposition, and you get more hypermobile from that gene being expressed through chemical exposure? That's a mast cell perspective. How many people have gut issues? Or autoimmunity, right? And so it's one of those things where, MCAS is a very complicated thing, and some of these people with MCAS are so sensitive to stuff that literally the fillers and stuff. I was reading a textbook on, it's called Disjointed, and it was written by a bunch of experts on hypermobility. And one of the interesting things in that book that I learned is that some people with hypermobility, is this a mast cell thing? I don't know, react with cellulose.
Which is in everything, every supplement.
The capsules, yeah. And so all of a sudden, I always ask my question, are we seeing, is this the same phenomenon with a different expression?
Yeah.
So I kind of put those things in my brain, these little places I put things to recall at a later date. So ultimately with this, what's the root cause? And a lot of times with these patients, you start doing mast cell therapies to calm that thing down so that you can change your diet, so that you can change your environment. Because when mast cells are flaring, the mast cells release not just histamines, there's a couple thousand mediators that are released, and some of them are neurotropic or neuroactivating mediators. Maybe that was actually an interesting question. Maybe that's the reason hydroxyzine and Benadryl, when I did my training, were used in the hospital with some schizophrenic patients to calm their schizophrenic flares down. Was this a mast cell phenomenon?
Well, we know that there are 4 types of histamine receptors: H1, H2, H3, H4. H1 is going to be Benadryl, and that's going to be respiratory and skin. H2, GI tract. H3 is your brain. H4 is bone marrow. And those mast cells hold inflammatory cytokines and histamine, but also platelet activating factor and other things. And the mast cell itself is the intersection of neuro and endocrine. It's the neuroendocrine kind of connection and integration of that information. And they're everywhere, by the way. And they're part of that system. They're there. We need them. But when they're overexpressed, they are problematic. And there's a condition called histidilia, where you actually have neuroinflammation from excess histamine, which is a neurotransmitter, freely crosses the blood-brain barrier, lights your brain up, and so you give that person an antihistamine, and all of a sudden they're sane. That's probably what happened there. The other confounding variable is something like limbic dysfunction, and the hardwired trauma of this can activate these mast cells. So it might be nothing else. So what's that in the way of the root cause? And then this is something that Heyman talks about, because I think it drives him crazy, is he's like, we didn't all just wake up and start having mast cell problems. Like, this isn't how we evolved. Yeah. It's a histamine issue. Some people have mast cell activation syndrome. Very few have mastocytosis, which is a true horrible condition that's incredibly rare. But the reality is that when we go back to CIRS and the mitochondrial genes that are dysregulated, there are 2 genes that are measured on that Gini test that are histamine pathways that get upregulated. One of them is called histamine decarboxylase. And if it's red, it is lit up like mine was, and that means every nucleated cell in the body is now an engine of histamine, not just mast cells. So you could do mast cell stabilization and they're still not feeling better. Why? Because you also have to address the other issue. So it's a lot of downstream and upstream intervention, plus reverse their CIRS. So in the context of, if the root cause is CIRS, theoretically, cure. If the root cause is CIRS then theoretically you have to figure out what the and is and address that as well. But you have to get aggressive with these patients and do up and downstream, because cromolyn or quercetin is probably not enough. You also need some antihistamines, diamine oxidase. Maybe they need benzos if they're really bad. There's a lot that goes on to unpack in that issue.
And actually, the last 3 questions are repeat, so that's actually
the end.
That's it. So
we did it.
We're done. So I hope you all enjoyed this. All things CIRS. It's been a pleasure. We will continue to do these. I don't want to say what our next thing is going to be, just in case it changes between now and then. So just in case it changes.
We're going to do more videos, more topics.
Yes.
We're going to discuss more. We're going to make more videos about certain topics. This was the big one for us to kind of get the point out, because it's the most confusing, the most complicated.
Yeah,
hopefully it was helpful.
Yeah, correct. If this was helpful, follow us however you do these things. Share the information, because ultimately, this is how we get the word out. This is how people learn about these things. And take care, be well, and we'll talk to you all soon.
Take care.